microphone working for y'all? A little slow coming on. So, can you hear me in the back? Yes? All right. Well, unfortunately, the curriculum often has us packing 2 hours of information into 50 minutes. So that you probably have learned that by now, I hope. So let's talk a little bit about lumbar spine and low back pain, general concepts, and then some typical lumbar degenerative disorders. So our objectives today are going to be to talk about the basic concepts of anatomy, biochemistry, biomechanics. We'll go over back pain and its evaluation, and then we'll talk about some specific reasons for back pain, including lumbar spondylosis, herniated nucleus pulposus, stenosis, spondylolisthesis, and then we'll see some cases. So basic concepts, it looks like our pen worked when we tried it. So we're going to go over some anatomy, some biochemistry, and some biomechanics. Anatomy, of course, you all know this down pat from last year, right? So you had great detail on the spine. So what you see is the vertebrae in the front. Stacked in between are the discs. On the front is the anterior longitudinal ligament. In the back, what you can't see is the posterior longitudinal ligament, because posteriorly here you've got pedicles, and then the spinous processes and the transverse processes, and then the nerve roots. Okay? Remember all that? So, all right. So if you look at an axial view, you see the vertebral body in the front. This is where the dura is with its contents of the nerve roots. Most of you remember digging those out and seeing the dentate ligaments and stuff at the spinal cord level. Remember, in the lumbar spine, the spinal cord basically tapers at L1 or so, and so you're going to see mostly nerve roots, and you won't see those ligaments, but you will see the little rootlets. The dorsal rami, which comes back here to the facet, which is thought to be one of the causes of back pain, and then the main root coming out this way, and then the sympathetic chain, of course, on the front. All right, so remember that your neural anatomy of the spine itself is going to be those rami that come off the root, and they come around where the disc is, and then the blood supply is segmental vessels coming in and then supplying the spinal canal. What this picture is these are the pedicles, so it's been sliced vertically in the spinal canal. So the front of the canal is what you see there. The back of the canal has been removed. Am I making sense? Coronal plane laceration, taken off the posterior element. Okay, so the nucleus pulposus is made up of proteoglycans, and there's a few cells, and then you have collagen, okay? The collagen is wrong button. The collagen is represented by the chains here, and then the proteoglycans are here. Remember that the proteoglycans have hydrophilic properties, so they're trying to bring fluid into the disc, and the collagen is a tensile force, so it's trying to restrain the disc from going beyond what it should. All right, so the normal disc is similar to articular cartilage, although it doesn't have as much of the collagen. It has chondrocyte-like cells, which are in the nucleus. They synthesize type 2 collagen predominantly. They synthesize proteoglycans and then some non-collagenous proteins, which are a very small minority of the contents. They also have some cells in the annulus, which also will synthesize 1 and 2 collagen, because that's what the annulus has predominantly. And of course, you have to remember that the aging of the disc, or the function of the disc, physiology of the disc, is all a balance of synthesis and degradation. So there are matrix metalloproteinases and then growth factors that are competing with each other and basically keeping a turnover in progress. This is an overview. I used to joke with people, just memorize this and you'll know all the basic science. But anyway, recognize that there are aging factors, genetic factors, nutritional factors, metabolic factors. I'm sorry, I can't even read that one. Thank you. Infection, and then mechanical factors, all giving you input into the disc. Some of those, for example, when you think of mechanical stress, some of those mechanical stresses are below a threshold where they actually strengthen the disc, and others can be over the threshold where they actually damage it. So when the musculoskeletal tissues typically are stressed, they will respond with more synthesis and so more strengthening, but it has its limits. All right, and then what about after all those influences? Well, you've got the growth factors, of course. You've got the metalloproteinases. You've got nitrous oxide. You've got oxygen radicals that also are feeding into this. And then on the synthesis side, you've got more of the proteoglycans. So this is also talking about different levels and how much water is there versus matrix versus the metalloproteinases in the three areas. Of course, you've got molecular with cross-linking, altered proteoglycans and altered proteoglycans on the pulposus and end plate. And then the annulus fibrosus has a lot more cross-linking. Remember, it's a barrier. It's a restraining thing. Does that make sense? Okay. And then at the microscopic level, you can get delamination, tears, and fissures. That shows up as cracks and tears. And then it can be thickening also, but then cracks and fractures of the vertebral end plate. So the vertebral end plate, when it responds to the stress, it will try and build up bone, and that's why you get the thickening of the cortex, and it'll be extra white at the edge when you look at it on an X-ray, for example. All right, then biomechanically, of course, stiffening and increased stress, you can get depressurization of your nucleus pulposus, and you can get weakness, bowing, or stretching of the annulus. And then, where am I? Imaging, you get osteophytes when you look at the annulus, and you can get reduced signal on an MRI of the disc. So the disc normally has a fairly high signal or light signal on an MRI on a T2 weighted image, and it turns darker as it loses the water. So we'll see some examples when we get to cases, but again, this is not something, it's an overview. It's not a memorize every little thing. So, all right, so a motion segment is defined as the two vertebral bodies, its disc, and the ligaments. Is there a question there I need to clear? We good? Okay. All right, so in this one you're seeing this vertebral body and this vertebral body with all of the stuff in between as the motion segment, okay? So for example, you would describe this as L3-4 or L4-5, depending on what level it is. Recognize that the disc responds to stresses. Here you're seeing it's compressive stress through the spine, and then it ends up with tensile stress on the annulus at the front and back. And again, right here is where the nerve is coming out of the foramen, and then you've got blood vessels around it. Okay, so normal disc under compression does this. The pressure is evenly distributed. It has tensile stresses in it that go in the different directions. However, when you do different postures, you get different loads. Okay? This is something clinically is important. Recognize that the two worst things you could do if you have a bad disc is, one, try and do something like a deadlift with weights, and number two, sit in a chair and try and lift something off the floor. Okay? All these other postures show you what the relative forces are. So supine is the least, side lying is a little bit more, standing is basically, an index to think of. And then you easily double it when you're doing some of those things. All right, so osteoarthritis affects the spine when it gets involved in the facet joints. Remember, you've got the disc in the front and the facets in the back. That's going to give you increased cartilage water content, proteoglycans alterations and degradation, collagen abnormalities with the collagenases starting to degrade the collagen, increased metalloproteinases, and then there's an IL-1 cascade, as it's called, with all these different products, leading to more degeneration. All right, so back pain. What's its importance? It is a clinical dilemma. There are many sources and some importance of what are called red flags. Okay, so why is it a big deal? It's the second most common reason for a physician visit in the United States. 50% of adults will have back pain in their life. $26 billion of healthcare expense, and that was in 1998. Most would suggest it's a little bit higher now. I haven't seen good numbers, that's why I haven't updated this slide, but everybody just says it's way more. So, big deal, right? So $100 billion in total costs in 2008, and that does include wages and lost productivity. About a third of that is the medical cost itself. 100 million U.S. adults had back pain in 2006, so it's pretty common and pretty expensive. So there's a clinical dilemma, though. So how do we explain asymptomatic individuals where when we get MRIs, 90% of them have degenerative changes, 30% of those have disc protrusions and herniations that when blinded surgeons look at them with allegation that there is extremity pain, they would suggest an operation. This is an asymptomatic patient, okay? And then approximately 20% of them have compression of the cauda equina, okay? All of these are asymptomatic. In addition to that, we have twin studies where they find twins where one was a labor job and one was a desk job, and they follow them in their 50s and 60s with MRIs, and they're identical. So can we blame the environment on it? We don't know. You know, we always think so, but how much of it, it's hard to say. All right, so what are the potential sources? There, of course, is the spine. That's the spondylogenic, okay? They can be neurogenic, so you can have a nerve sheath tumor or other kinds of tumors that are on the spinal cord or in the nerve roots or in the lumbar spine that can give you back pain. Viscerogenic, that's your pancreatitis. That's things like that. Your nephrolithiasis, you know, kidney stones, those sort of things. Can it be vascular? Yes. AAA can give you back pain before it makes itself evident in other ways. Psychogenic, I'm sure you've all heard of people that get psychogenic things. And then there's the non-spinal skeletal problems. So some people can have hip arthritis that they experience as more buttock and back than they do in the groin, for example. So you can have a non-spinal skeletal problem. All right, what are the red flags? Okay, red flags mean we're going to turn around and do something for this patient quickly because there could be something bad there. Okay, so a red flag would include, or could bring you to things that are like disc herniation or stenosis, but they can also lead you to infection or tumor. Okay, so what are those red flags? Incontinence. So cauda equina syndrome is when you have a large disc that affects the entire cauda equina. It's associated with incontinence, which is why it's on this list. It's also associated with perineal numbness, and it may be associated with weakness in the lower roots like L5 or S1. Typically, it is the lower lumbar roots. The next red flag is fever and chills, okay? Some people would add a history of ongoing drug abuse and that sort of thing, or immune suppression, you know, either diabetes or chemotherapy or things like that, because those can lead to the chance of a lumbar infection that if you're not thinking about it and asking those questions, you might miss. And you also want to get acting on an infection fairly promptly, I think we all agree. Unexplained weight loss, you're thinking about neoplastic problems. And then all of these need prompt imaging or prompt attention, and it kind of depends on which one it is for what you're going to get. Most of them, an MRI is going to be a very helpful thing, okay? So that would probably be the first line answer if you see something with red flags is, you know, get the MRI, okay? All right, so if there's no red flags, we differentiate things between back pain, which is very common, as we said, 50% of adults, and it's not something that needs to necessarily be acted on by a physician other than advice and counsel to the patient, okay? And typically that advice and counsel is going to be 6 weeks of physical therapy, anti-inflammatories if they can tolerate them, if they don't have a contraindication, and the exercise and activity modification are the keys to this. The acute occurrence of back pain, this is what we would call the art of medicine. Voltaire said the art of medicine is entertaining the patient while nature lets them get well. Okay? So fundamentally the NSAIDs do help because they do have analgesic properties and anti-inflammatory properties. Physical therapy, some of the modalities, you know, the heat, the stretching, things like that often help. But they don't affect the natural history. The natural history is still 70% will be over their back pain in 1 month, 80% in 2 months, 90% in 3 months. Okay, so it basically goes away whatever you do. Leg pain is going to be, if it is neurologic from the spine, it's going to be called radiculopathy. It's, oh yeah, sorry.
Last week we heard about mastectomy and sham surgery that was shown to be rather effective as actually doing a meniscal repair. Excuse me.
Okay.
Are there any kind of analogous studies with back pain?
Unfortunately, no.
Can you repeat the question?
I will. So he said that last week he heard about meniscectomies and sham surgeries, and there being no difference. So sham surgery in the spine has felt to be much too invasive to be able to meet the ethical standard of being able to do it, right? You don't want to do something that's not geared toward helping somebody if it's going to involve disruption of the paraspinal muscles and that sort of thing. The reason that some people did it with meniscectomy is because of the difference in the individual morbidity, morbidity, so to speak, of arthroscope. So it's not that much. So good question, and a lot of us have talked about it until we're blue in the face. It's like there's a lot of things, and so that is why when we look at surgery, we'll restrict it to very specific indications for lumbar spine problems. Okay. So getting back to radiculopathy, that's when you have nerve compression and you feel the pain down your leg, and it can be associated with either motor or sensory decrease. That may have a similar initial treatment. Again, the same odds of getting better, 70% at 1 month, 80% at 2 months, 90% at 3 months, even with radiculopathy being the only symptom. Okay? And then the other symptom that you might see is neurogenic claudication. Does anybody know what that is already? Okay, so neurogenic claudication is similar to vascular claudication. That's why it's called claudication. It basically means the further you go doing something, the more it's going to bother you. Okay? And we'll go over some differences between vascular and neurogenic here in a minute. So evaluation of the patient, of course, includes history, physical, diagnostic tests, and predictors. The history, you want to know the quality. You've had this multiple times, I'm sure, in the, what's that area that we go to where you've got the clinical exam stuff? We get to watch you through the mirror and all that kind of stuff. So I'm sure you've had all that several times, but we'll review it again. Quality of the pain, severity of the pain, usually a numeric scale. Where is it? What makes it worse and better? How did it start, or when did it start, and what are the effects through the day, that sort of thing. So you want to ask all those questions because they help lead you to where you're going, right? So associated characteristics, again, numbness and weakness can be there. Incontinence, of course, would be a red flag that you'd want to jump on. And then functional limitations, the patient may tell you that they can't do their groceries anymore because they can't walk more than a block. And in the grocery store, they're having to walk through the whole store. Things like that. All right, so past medical history can also contribute. Remember, we talked about the different sources of back pain. So you've got vascular disease that may be causing it, metastatic disease, autoimmune disease. Y'all have heard about Reiter's and ankylosing spondylitis and that sort of stuff. So, and then GI problems, urologic disease, endocrine disease, and other spine disorders or previous spine surgery or spinal problems. Family history, malignancies, that, they contribute a little bit. Deformities, rheumatoid diseases, and familial disorders. They're all pretty rare as far as causing major problems, but they do occur. So the review of systems must include, remember the red flags, fever and chills, unexplained weight loss. Then you're going to add incontinence, of course, and then are there neurologic changes and that sort of thing. The basic exam, obviously you're going to make general comments about how they look and what they do. You want to examine their gait. A person with radiculopathy is going to have a limp. A person with hip arthritis is going to have a limp. A person with knee arthritis is going to have a limp. There's subtle differences among all those that are probably beyond the scope of today, but there's something to be aware of. If somebody's limping on one side and it turns out that that's the same side that their pain's on, it kind of fits. You want to inspect the spine. Patients that are in spasm will not be very flexible, and you'll be able to palpate their muscles and feel them very hard in spasm. You can also see if they are asymmetric, which could be the result of some scoliosis that's there. You want to palpate the spine and identify any areas of focal tenderness, and then checking their range of motion. The formal way, quote unquote, of checking range of motion is actually using what's called dual inclinometers. They're basically BBs in a circular array of degrees, and you have to use 2 of them at a time. And you put one high on the spine and one over the sacrum. You have them bend. You have to measure the differences between those two every time. Not many people have that kind of time in clinic, so it's very simple. Have the patient bend forward, reaching their fingers as far down their legs as they can go without bending their knees. Very repeatable for flexion. You want to test extension not so much for a degree measure, but to see if it aggravates their pain. And then you've got side-to-side bending, and then I wouldn't recommend this for people you suspect a herniated disc, but you can look at rotation as well, okay? The reason I don't want you doing it for people which you suspect with a herniated disc is because that's one of the theoretical things that can actually overcome the shear forces in the disc is when you're twisting the disc as opposed to loading it. So, all right. So the other thing you want to test is their motor strength. Do you all know the motor grade stuff? Have you seen this before, heard this before? Okay, so I've seen some yes and some no's, but it's basically here, okay? 0 is they have no voluntary contraction, okay? You can't see it, you can't feel it, nothing happens. 1 is a contraction that's not really effectual, okay? So you'll see it change in contour, you might be able to feel it get tense, but it doesn't effectively move the joint, okay? A 2 is if there's motion of the joint with gravity eliminated. So if I'm testing biceps here, it's not against gravity, okay? Triceps the same, right? Not against gravity. If I get them down here and they can't do it, but here they can go full range, that's a 2, okay? Down here, once they can get it all the way to a full range, that means it's a 3. Recognize that could be a feather, or it could be a dumbbell, okay? Or it could just be the weight of their arm. So 3 and 4 are a big range, okay? 4 is resisting gravity and some resistance, and then 5 is, quote, normal. Recognize that if you have a college football player that comes off the field with a stinger, you may not be able to tell if they're 4 or 5 because they're going to be stronger than you anyway. And you might find that their first day in the weight room afterwards, they say, you know, I used to be able to curl 75 pounds with my arm, both arms individually, and now I can only curl 50 on one side. That's a weakness, okay? So I know some of you guys are in the weight room all the time and recognize that, okay? On the other hand, you may find somebody that you think is a grade 4, but they're grade 4 everywhere, and they're 75 years old, and they have a history of, you know, rheumatoid arthritis and congestive heart failure, okay? They're not going to be your 5, okay? So 5 is a very qualitative pick, all right? Now, what about motor levels? So this is where do the nerve roots go kind of question, all right? So T1 through 12 go to the intercostals. L1, 2, and 3 give you hip flexion. Do you remember what that muscle is? Psoas muscle, iliopsoas, right. And why is it called iliopsoas? Right, because it starts off. Very good. All right. So the next L2, 3, and 4 give you knee extension. L4 gives you ankle dorsiflexion and inversion. Okay. L5 gives you the great toe extensor. And S1 is ankle plantar flexors. Okay. These are based upon trying to find as much isolation of the motor segment as possible. It was developed by people of a society called ASIA, American Spinal Injury Association, and they looked at when they knew what an injury was, what was the result. So it's more reliable and specific than the general things you'll see in your textbooks that talk about anatomy or neurophysiology, because they'll tell you where there's mixtures. And this is trying to isolate it as much as possible. So in other words, there is some degree of overlap with the other muscle groups. All right, sensory exams also are fairly straightforward. The groin is T12. L1 and 2 are kind of between there and the knee, okay? It's easy to remember. L3 is medial knee, okay? L4 is over the medial malleolus. L5 is on the dorsum of the foot and toes. And S1 is the lateral calcaneus and also contributes to the bottom of the foot, okay? So if you're at 4:30 in the afternoon, it's your kid's birthday, and somebody comes in with back pain, there's a very quick and easy way to check if they've got a weakness. You have them walk on their toes, which tests what? S1, and you have them walk on their heels. And if their entire foot is up and balanced, what have you tested? You've tested L4 and L5. Because if it's L4 without L5 balancing it, it's going to invert the foot. Okay? And so now you've done a neurologic exam that tells you that you've got grade 4 or better in the lower extremities. You know that the most common herniated discs are at L5S1 and L4-5, and next up is L3-4. So you've ruled out a neurologic deficit for the majority of any any disc herniation causing a neurologic deficit. Okay? Then you can encourage them quickly, say, we'll see you in a month, try these things. Most people get over this, and you're good to go. Okay? And you can make the birthday party. All right, reflexes. This is really for just completeness. Many times we don't check reflexes unless we find another deficit. But knee jerk gives you quadriceps, of course. Ankle jerk is the Achilles and gastroc soleus. And then if you're concerned about a upper motor neuron, you want to check a Babinski. All right, so diagnostic tests include radiographs, which should always be the first thing you get. Next would be an MRI currently. You also should be aware of a myelogram and a CT scan, because many patients still have pacers that are not MRI compatible, or they have other kinds of stimulators and can't have the magnetic field. So a myelogram is an injection of an iodated dye into the thecal sac. So it is basically permeating the spinal fluid. And then a CT scan is done after that to look for nerve compression. So poor outcomes. If patients have back pain this is poor outcomes from surgery, sorry. Patients that have a majority of back pain as opposed to leg pain don't do well. If they have a lot of medical comorbidity, and diabetes tends to be one particular that's aggressive about making it difficult to get a good result, revision surgery generally doesn't do well. Patients with hip arthritis, and you do their spine, they may not get much better. And then lumbar fractures also tend to have, these are basically compression fractures in the elderly, tend to have a little bit more poor outcome than you'd like to see. All right, so what's lumbar spondylosis? It's the spectrum of degenerative changes that happen in the lumbar spine. So a lumbar disc bulge is one of the things that you would consider as a starting point, and it's a diffuse non-focal protrusion of disc material beyond the confines of the normal disc space. In other words, it goes where you don't think it should. Then a lumbar disc herniation is a focal displacement of a nucleus, annulus, or the end plate material beyond the osseous confines of the vertebral body, which results in displacement of epidural fat, nerve root, thecal sac. It can also happen in the front of the spine as opposed to the back where the canal is. So while this definition is the most common, you do need to look for it in other areas. So here's some examples. And the lumbar disc herniation actually can be graded somewhat from this is the broad bulge. This is a herniation where the material is coming through the annulus to the PLL. This is where it's come actually through the PLL, posterior longitudinal ligament, if I'm saying that too quickly. And then here's one where a piece of the nucleus has actually come through and separated from the disc itself. Okay? There's some work that has tried to look at whether the surgical outcomes are better with some of these, and it looks like this one and this one, surgical results are the best. Looks like, because we don't really have enough volume to say so. All right, so clinical pathophysiology of radiculopathy. Okay, so when you have a herniated disc, why do they hurt? Okay, so the number one thought is it's mechanical compression of the nerve. Okay, and that probably is the majority thing. Second thing that can happen is when that nucleus herniates, I told you that there were non-collagenous proteins that were in there. Those are nociceptive. And so if you have an extractive nucleus and you don't put any pressure on the nerve, it can still generate a nociceptive response. Okay? It's thought to be that TNF alpha is the main contributor to that, or mediator of that, and it is thought to do that through some apoptosis of the dorsal root ganglion. All right. Another thing is the inflammation that can happen as a result of either mechanical compression. So the mechanical compression happens, but also realize that under normal circumstances, the dorsal root ganglion moves about 1 centimeter at the lower levels of the lumbar spine when one ambulates. So if you can imagine you've got this dorsal root ganglion, which is an enlargement, moving back and forth across a narrowed area, that's going to be abrasive, so to speak, and can lead to inflammation. Okay? So that inflammation can result in edema. If you're swelling in an area that's confined, it's going to make the pressure on the nerve root more, right? Secondarily, because it's getting bigger. And so that's another thought of why inflammation is contributing to the pain. And then arterial perfusion and venous congestion are both implicated as other things that change and could be resulting in some pain in the nerve root. So you can imagine if you're not getting good blood supply to the nerve root, it's ischemic, much like the heart gives you heart pain, although it's muscular, the nerves can also give you some changes. Okay? All right. So clinical symptoms of radiculopathy are pain in a dermatome, numbness or paresthesias that are relevant to that root segment, weakness in the motor group, and then pain with ambulation, coughing, sneezing, and Valsalva because the increased pressure leads to more irritation of the nerve root. All right? So the treatment of lumbar disc radiculopathy, as I mentioned, 90% get well on their own, and that's typically over a 3-month time period. Physical therapy has reduced severity of the symptoms and the work missed, but doesn't tend to decrease the amount of time the symptoms are there. Okay? Anti-inflammatory, again, improves the symptoms, and it may be addressing that small inflammatory component. Muscle relaxants are sedating, but they do show some helpful effects on the patient's symptoms. Steroids are very inconsistent. It's very hard to use evidence-based medicine when something has been utilized very frequently for very long, okay? And so it's very challenging to try and convince emergency physicians, primary care physicians, that maybe they shouldn't use steroids for the initial presentation of radiculopathy. The effect of steroids seems to be mostly a euphoria for those that get that, and that makes it easier to live with the pain. But as you know, there's also negative consequences to steroids, and they don't always make people feel euphoric. Some people feel sicker. And so it's really something that you shouldn't be doing as a first line or even second line. Okay? All right, and then epidural or selective nerve root blocks can be very helpful. Basically what this is putting a combination of numbing medicine and some steroid around the nerve root or around the dura, depending on which approach is used. And then failure to respond after 4 to 6 weeks, consider surgery. And that's going to depend on the severity of the symptoms and any neurologic deficit that's present. Okay? Cauda syndrome is estimated 2% of lumbar disc herniations, and that was in a center that basically made their name by talking about Cauda syndrome, and so it may be a little bit biased. It's severe bilateral leg pain, as I mentioned earlier, weakness, saddle anesthesia, urinary retention, followed by urinary incontinence, and sometimes can be bowel incontinence, and impotence can happen in men. All right, the treatment is early recognition. The problem with it is it's often not recognized. So that's why we emphasize it as a red flag. That's why we're emphasizing it as a clinical exam here. And the reason that it's not recognized is people aren't thinking about it. They think it's just another routine back pain. Okay? Now, if treated in less than 48 hours, the recovery of bladder is 95%. Okay? If treated after 48 hours, the recovery of the bladder is, as you see, much less, or in the 40%. So 63% require a catheter program. Okay? So that's why there's an emphasis to try and get to it quickly. Okay? Permanent. Yes, permanent, unfortunately. Okay? So the next category to think of is spinal stenosis. When you have the degenerative changes happening at both the facets and the disc, they spread. That makes the canal that they've made smaller. And so you get a narrowing of the spinal canal caused by causing compression of the neural elements. Okay? So intervertebral disc degeneration is part of it. Then the two joints in the back are the facet joints, and their interplay is it can start at either one and it'll affect the other. And so both will kind of seesaw back and forth as it progresses. All right, clinical presentations, usually over 50. They can have leg pain that's either sciatica or neurogenic claudication. Okay? So the sciatica or radiculopathy is what we talked about a minute ago, and the neurogenic claudication we'll go over some more detail. It's typically worse in extension because when you extend, it gives more overlapping of the facet joints and actually shrinks the canal. It also shrinks the foramina because of facet joints posterior margin of the foramen. So I see some puzzled things. So if you think of the neural foramina as a circle, but it's two C's, if you overlap like that, which is what happens when you extend your facets overlap and they slide, so that makes the hole narrower. Is that more clear? Okay. It also tends to narrow the central canal as well because of just how the disc bulges back further and that sort of thing. All right, so, and it's usually better in flexion. So one of the things patients will tell you is when they go to the grocery store, they can make it because they're leaning on the cart all the way around, okay? Or if they use their walker. They don't want one of these stand-up walkers if they've got neurogenic claudication, okay?
There's a question there.
Where's the question?
Okay.
Did I answer it? Right, so recognize if I flex forward, it opens the canal relative, right? And if I extend, it makes it smaller. So they prefer to do this. Make sense? So what are some other things about neurogenic claudication versus vascular? Okay, remember vascular, they walk a while and they get calf pain and they have to stop, right? So the distance in vascular is usually much more consistent than the distance in neurogenic. Okay, that's one thing. Relief in vascular can happen just with stopping their ambulation. They can stand and it'll get better because their muscles are no longer firing actively. Okay? In neurogenic claudication, they generally want to sit or they'll bend forward and rest on their knees because they need that flexion to basically get less compression on their neural elements. Okay? And then a vascular person is not going to like going uphill. They're not going to like to ride a bike. A neurogenic claudication can ride a bike as long as their heart will let them. Okay? They can go far because they're flexed in that posture. Okay? And if you imagine going uphill for the neurogenic, they're flexing forward to go up the hill, right? Going downhill hurts a neurogenic because they're in extension. Same thing with stairs, up and down, the same thing. Okay? Neurogenic is generally proximal to distal, so it starts in the butt and goes down to the thighs. And in the vascular, it usually starts in the calves and works its way up. And then, obviously, in vascular, you would expect poor pulses. Neurogenic, you would expect normal pulses. Okay? Has that been up long enough? You guys have this to look at later, right? Okay. Physical exam for stenosis is generally nonspecific. As I mentioned before, they may have flexed gait, they may have a shortened stride, and if they're the sciatica component, then they're going to limp on that side. Okay? They're not going to like extension. And the neurologic examination is more often than not normal. Okay? In some, you'll find a mild L5 sensory deficit. Sometimes you'll find a mild EHL weakness, so a grade 4 as opposed to a grade 5. And tibialis anterior if it's the next level up, okay? And if it's long-standing, you'll get patients that come in with atrophy and sometimes even a foot drop. You know what a foot drop is? Yeah, okay. So, and then reflexes are generally unreliable. In other words, they don't make a difference in your decision process. All right, so myelogram CT scan has high specificity. You're looking for an hourglass appearance in the canal. 24% are false positives. And then you get sagittal recons to look at the foramen. That is differentiated against the MRI, which is non-invasive, doesn't require the needle. It gives you all the planes without having to reconstruct them. 21% false positives. The quality is variable. It's less so now than it was, say, 5 years ago, because more and more people have upgraded their imaging. But even with a 3 Tesla image, if they don't program it right, they can come out real grainy and not very effective. And then it's really good for looking at the foramen as the nerve root leaves. Here's an example of a 70-year-old with bilateral leg pain. This is a triangular canal, and as you know from anatomy, the canal was an oval, okay? And why is it triangular? It's because this facet is hypertrophied, pushing the capsule and the ligamentum flavum in this direction. This one is done it the other way, so it's taken the far edge of the curve out, and then, of course, the disc has bulged backwards, okay? So it's known as a trefoil canal. It can actually get a lot worse, so it actually looks like a Mercedes star upside down. So, all right, and then on the side, on this view, you see where he's looking like an hourglass. So open canal above, open canal below, but then he's got that narrowing there. Can you appreciate that? Okay. All right, so non-operative treatment, basically trying to manage the symptoms. Activity modification, physical therapy has reached a controversy because when you take people with a stiff spine and try and make them more flexible, they don't always feel like it. In other words, it contributes to pain rather than relieves them. Anti-inflammatories are a first-line use. Epidural steroids often will help the leg pain but aren't 100% reliable. And then since these patients are usually over 50 and most of them over 60 and 70, you need to think about other medical issues and, of course, consider depression as an influencer on their symptoms. All right? Surgical treatment is for progressive symptoms. In other words, it's getting worse over time. It's a quality of life decision. It's not a functional, life or limb threatening kind of thing. And they're most successful when patients have minimal comorbidity, and it requires a meticulous technique, which we'll go over some of here. So the classic for taking care of either a herniated disc or a lumbar stenosis is a laminectomy and facetectomy. So what that does is, here's a cross-section with your disc in front, facet joint here. So this is the lamina spinous process, and you take out the majority of the lamina here and all the spinous process, and you undercut the facet joint a little bit here. You can take up to 50% of the facet joint total. So if you look here, they've done about 25% on one side and 25% on the other. You can take out that much without having them predictably get unstable. Okay? All right, spondylolisthesis. So why do we have a word that's so similar to another word? Well, spondylo, of course, is spine. Osis means the degeneration, the aging problem. Listhesis actually means it slid forward. Okay, so this is a deformity. All right, so spondylolytic spondylolisthesis is the one you hear about if you're really up for peds, okay, because this is what happens in the young female gymnasts or the linemen that are playing football, and it happens with frequent hyperextension, okay? You get fundamentally a stress fracture, and that's called spondylolysis, which means there's a lytic lesion there. And then if that's, in some patients, if that's not taken care of, it can result in the slippage forward because you've lost the posterior part of the ring to stabilize the spine. And that's when you get the spondylolisthesis. Okay? If you have a young adolescent and they have spondylolysis, you have to remove them from the activity and hope that it heals. It does in about 90% of them, okay? But they don't like it because they want to keep doing their stuff. All right, then there's degenerative spondylolisthesis, and that's when you have the degeneration that we've been talking about with the disc, with the facets. And it's more common if your facets are more sagittally aligned, okay? So most facets are off angle in the back, probably, 20, 30 degrees. And if they're less of that, then they have less resistance to the vertebral body degenerating and sliding forward. Does that make sense? If it was 100% coronal, that wouldn't happen at all, right? Okay. And so here's an example of a 4 or 5 spondylolisthesis. And you can imagine how that would narrow the foramen because you're pulling this forward and this is staying back. And you can also imagine how it would narrow the canal, right? If you have 2 rings centered over each other, it's a nice big hole, but if you start sliding them, it gets narrower, right? Okay, so there's other kinds of spondylolisthesis, congenital or dysplastic, and that is just an elongation of the pars interarticularis. And then you can also have acute traumatic. So you can have a patient thrown from a vehicle that comes in and they've had an acute traumatic spondylolisthesis. All right, so let's see some cases. Here's a 54-year-old male, right buttock and thigh pain. Progressive with his ambulation. It's relieved by rest. It's not responding to anti-inflammatories. He has minimal comorbidity, and he has some mild back pain. What do you all see? So let's start with basics. When a clinician asks you, what do you see, and there's an MRI up there, you say, I see a lumbar MRI, sagittal view, okay, with, sorry? No contrast. No, this is a T2 image. This one doesn't have it, but many times you'll see down here it'll say, oops, sorry. Down here it'll say T2, so you can read it instead of having to know it. So, all right, so we've talked about several things. Is there a listhesis there? So I don't see any listhesis. So you're looking at the back of the vertebral bodies lining up, right? So no listhesis. And you double check it by looking at the front, okay? So remember I talked about signal change as being one of the signs of degeneration, right? So the closest to normal is way up here. It's got a little bit of dark, but most of it's light. All these are dark, okay? What do you think about the space between the bones? It's inconsistent. Do you think it looks normal to what you saw in an x-ray in general? Or what you saw, well, in anatomy I can't say because some of you had old spines. So remember how we looked at first, we saw the bulges, right? Is this a herniation? Probably not, because the number one, the signal intensity is pretty homogeneous through here, and 2, it doesn't seem like it's out and away. Okay, so you've got bulging there, you've got bulging there, you got a little bit of there, some down here and some down here, but not too bad. Okay, so if we look at the axial views, here's L2-3. Remember that triangular canal we talked about? So a working diagnosis might be stenosis. Fair enough? Okay. So he had a lumbar decompression, and there was no change in his pain postoperatively. He got sent out from this hospital, came back to the hospital I was in at about 9 months, and at that time he had progressed to the pain not allowing him to walk almost at all. Okay? He was readmitted for workup of recurrent neurogenic claudication. After being in the hospital for 3 or 4 days, they finally consulted OrthoSpine, and we looked at him and said, maybe we want to get a hip x-ray. What do we see here? A mass on the femoral head? Well, there's something clearly wrong on the femoral head. and the adjacent acetabulum and the joint itself, right? So if you look, there's a divot here in the femoral head. So normally it'd be round like this. Any idea what could cause the femoral head to get weak? Avascular necrosis. He had a profound history of alcohol use and abuse. Okay. When I examined him, he was very coxalgic on the right, so he was very antalgic on the right and protecting his hip. And so we did his hip replacement. He did fine. So next case is a 60-year-old male, back and leg pain, neurogenic claudication, can't do his work, can't do his desired activities. He's basically completely healthy and had normal neurologic findings. Here is his X-ray. What do you see here? You can get it. Come on. You've already said it on the last one. There you go. Everybody sees the spondylolisthesis. The front of the vertebral body doesn't line up with the front there. The back doesn't line up with the back. Here is his MRI. When he lays down, it looks less. You see that? So he goes from that. When he's laying down, he's a grade 1. That's basically a grade 2. Okay. So grade 1 is 0 to 25%. Grade 2 is 25 to 50%. Grade 3 is 50 to 75%. Grade 4 is 75 to 100% slippage relative to the next one. Okay? So he gets better when he lies down, but he still has it. And then when I was telling you about the sagittal plane being good for foramen, this is the neuroforamen. This is the nerve root at that level. The white is epidural fat. And you can actually see the blood vessel right there too. Next one down, you see a little bit of epidural fat around it. But look at this here, and you can see that the nerve root is actually now pinched between the pedicle and the disc below. Everybody get that? Want to see it on this side? So right here, this is pedicle, the lighter gray. The dark is the nerve root. It's kind of elongated in this direction. And then this is the disc down below. This has slid forward relative to that. Okay, and this is the axial view showing some facet hypertrophy and then the narrowing of the foramen on both sides. Post-op, he had a decompression and fusion, got back to his work, and no further problems. Questions? I'm sorry I've gone over your 50 minutes, but like I said, it's like, trying to drink from a fire hose, right? Everything pretty straightforward?
Thank you.
You'll get all the answers right?
Let's take a 10-minute break, and then we have Dr. Sanders.
Hi.
Just to clarify, neurogenic claudication, that just Okay, question. So, when someone gets osteoarthritis,
I support Samantha once and follow her mom blog. Yeah, all these mom blogs are like trying to
just started osteomyelitis.
That's what you
Go towards
Yeah, all my mom.
Sorry. No, I think that. I mean, septic arthritis and osteomyelitis.
Use the restroom real quick up there.
You get relaxed with the spine right now. I'll tell you how. It's like their body craving.
Is it like there's enough that luxury in front of it. I was trying to figure out what came first, the chicken or the egg, whether it was maybe the. So I thought it was like no, I didn't have any jelly sometimes at all. But the test came back as salmonella non-tofu. But it was just like chicken chills. Really intense. Anyways, you can answer this one.
I noticed when I brought up rheumatological disorders, they all,
Oh yeah.
oh yeah.
I know it. I've taught them that again and again. Thank you for coming here.
No
I
problem.
thought you were here this morning as well, but you weren't for the MSK physical exam session.
No.
No?
Am I on for tomorrow?
No, it doesn't look like you are. If you want to be, you're on for. I'm not in charge of that part. That's the other course. So nobody invited you this year?
I don't remember.
Oh. I mean,
Because you always did everything. So.
yeah, it's kind of.
But you can't do everything
I can't
forever.
do everything, so I let the P2 folks handle that. But next year, if you're interested.
I was also
Yeah, I'd like to know about it so I can try and schedule it. Hey, good to see you.
Get them warmed up with lumber.
Yeah, and it's the first time I was able to do it in a lot of time. Actually, I went over about 3 minutes instead of more like 15.
Because that's in class, not in this class. It's on, yeah.
The Cure Cloud case is different. And that's with our group as well.
Yeah, on your own time. You just have to submit it by
Now,
Yeah, I
are
was
you?
surprised you hadn't said yes to those MSK physical exam sessions. And then I realized that maybe
So-
because maybe emailed you.
Well, yeah, that's what it was.